So we'll get started. Thank you everyone for joining us. And thank you, Gretchen Olson. It is Babcock ice cream, which is what we were talking about. So maybe a little cold right now, but they do an amazing job. So today, introducing our guest speaker, Dr. Dawn Hershman, will be Dr. Ruth O'Regan, our Division Chief of Hematology, Oncology, and Palliative Care Medicine, Deputy Chief of Cancer Center, and a woman extraordinaire. So with that, I'm going to hand it over to Ruth.
Thank you, Lynn. Well, we're delighted to have Dr. Hershman here with us today from Columbia University. So Dawn went to medical school at Albert Einstein in New York and then did her residency and fellowship and clinical fellowship at Presbyterian Hospital in New York. She then joined the T32 program at Columbia University and has been there on faculty, moving up the ranks since that time point. She's highly accomplished and internationally known in the field of breast cancer. She's currently an American Cancer Society Professor of Medicine and Epidemiology with tenure at Columbia University Medical Center. She directs the Breast Oncology Program and is leader of the Population Science Program at the Herbert Irving Comprehensive Cancer Center. She's developed nationally recognized expertise in cancer care delivery, late effects of cancer therapy, health outcomes, and health disparities research, and has received research funding from multiple sources, including the National Cancer Institute, American Cancer Society, the American Society for Clinical Oncology, Department of Defense, Susan G. Komen Foundation, and the Breast Cancer Research Foundation. She's mentored numerous faculty members who have been granted mentored career development awards and has a very strong publication record with over 400 papers, including many in high-profile journals. As far as national leadership roles in oncology, she's vice chair of the SWOG NCORP research base and co-chair of Cancer Care Delivery Committee. She serves on the breast cancer and the cancer care delivery steering committees of the National Cancer Institute. She's on the editorial board for the Journal of Clinical Oncology and is an associate editor for the Journal of the National Cancer Institute. She's received numerous awards, including the Advanced Clinical Research Award in Breast Cancer from the American Society of Clinical Oncology, a Conquer Cancer Foundation Research Professorship in Breast Cancer Comparative Effectiveness Research, the Advanced Medical Achievement Award from the Avon Foundation. She's also a Komen Scholar and was recently awarded the Conquer Cancer Foundation Women Who Conquer Cancer Mentorship Award. So I didn't realize you had so many awards, Dawn, so it's amazing. And we're delighted to have you here. And she's going to talk about a very important topic for us in breast cancer, which is adherence to the medications that we want our patients to take. So thank you, Dawn, for joining us today.
Well, thank you so much for inviting me. I guess I'm going to be talking a bit today about medication adherence in cancer and in general. A topic that I think reaches many across multiple medical specialties. And as you know, our old Surgeon General has said in the past, drugs don't work in people that don't take them. And we know that over time, we've had this miraculous explosion of new ways to treat multiple medical chronic conditions, many of which are oral. And adherence and uptake of these medications can be quite problematic. The problem of medication adherence is, really profound. There are over 145 million people suffer from chronic conditions, and it's thought that non-adherence to the medications to treat those conditions result in cost to the U.S. healthcare system of about $300 billion annually. Over 125,000 premature deaths are associated with non-adherence, and there's a cost to the pharmaceutical industry as well. But I think, no matter what field you look at, probably about 2/3 of all patients are non-adherent to their medications. Either they don't start the prescriptions that they're given, they don't take their medications on a regular basis with sort of skipping, or they stop their medications prematurely. So when you look at the whole literature on adherence, I think it's important to recognize right off the bat that adherence is something that's extremely difficult to measure. Most of the research that is done looks at pharmacy records. The advantage of pharmacy records is that you can look every time a patient fills a prescription. If patients are unaware, so it doesn't alter their behavior, you can try to capture medication possession ratio, which is the number of pills supplied over a fixed period of time. You can you can capture patients over a period of time if you know what they're supposed to take and when they're supposed to take it. One of the real problems with pharmacy records is that patients' insurances change. So if you're looking at claims, it can be sometimes challenging to capture patients over a long time. It can look like patients discontinue even if they don't. And now that we've moved to an era of auto refills, patients can continue to get medications. It can look like they're taking them because the prescriptions are being filled, but patients just stockpile them at home and don't actually take the medications. You can look at biomarkers, which has been done in HIV research. You can look at blood pressures and cholesterol. It's often these things are reliable. They require somebody to come in, and it only measures a single point in time. So looking at viral load or blood pressure or LDL can be a reliable measure to a certain extent, but if you're resistant to the medications, it doesn't necessarily measure adherence. You can ask patients. So it used to be thought that this was not so reliable. I think over time, we've seen and others have seen that actually patients are pretty clear if they've stopped taking a medication. They pretty much tell you, but it doesn't really get into fine granularity of medication possession ratio and whether or not somebody's taking them every day. There are numerous patient-reported outcomes. There's not a well-validated single measure that everybody uses, and sometimes that can be hard to capture incomplete use. You can look at electronic pill bottles, which is something that's important in a lot of research studies where every time somebody opens a pill box or pill bottle, it electronically captures it. The biggest problem with this is that it usually is good for short-term studies, not long-term studies, and the patients are acutely aware that they're being monitored, which can alter their behavior. And more recently, we've done research looking at digital medications, which you can actually co-encapsulate a pill with a little bit of copper. Patients can wear a Fitbit type device, and it essentially electronically timestamps every time somebody takes a medication. That's good for things like DOT, and if you really have to capture that a patient's taking their medication for public health purposes. So what about non-adherence in cancer? I think we initially, when we started to look at this, we figured, well, cancer is such a scary outcome for so many patients that, of course, patients were going to be adherent to their cancer medicine, where they may not be adherent to antibiotics or blood pressure medicines because they don't necessarily realize the importance of the outcome. So that got us starting to look way back about 15 years ago at issues related to hormonal therapy in breast cancer. We know that for about 2/3 of all patients, they have hormone receptor positive breast cancers, that for those patients that hormonal therapy is the most effective way to reduce recurrence. We have learned over time, we gave medicines for 5 years. We've started to learn that it's not just short courses, but longer courses, 10 years, can improve outcomes. It's both pre and postmenopausal women are receiving medications for long periods of time. And in addition to giving medication for early stage breast cancer for long periods of time, we've started to give it for more pre-malignant conditions like DCIS, and even for prevention, where patients are getting it for 5 years. And even amongst patients with metastatic disease, as we've made so much progress, we're not only giving one medication orally, but we're giving multiple medications orally. And sometimes these patients are on these medications for many, many years. So this sort of crosses the entire spectrum. Our eyes sort of first became alerted to the fact that adherence could be a problem with tamoxifen by this study that was done by Ann Partridge back in 2003, where she looked at a smallish cohort of patients that were receiving Medicaid, and found that in terms of prescriptions, by the fourth year, only about 50% of patients were getting their prescriptions refilled on a regular basis. So simultaneously, we were looking at larger databases to look at issues related to patients not completing chemotherapy and endocrine therapy. And we did this study in collaboration with Kaiser Permanente. And we looked at over 8,000 patients enrolled in Kaiser, looked at their refill patterns. We had information both on prescription refills, but also could calculate medication possession ratio. And we found about 25% of patients stopped taking their medication early. And we found that about 25% of patients were taking the medication less than 80% of the time. And that 80% of the time was seen as like, the criteria for adherence that most studies had looked at. And when you look at that all together, it sort of represents only about 50% of patients taking it for the full duration, greater than 80% of the time, which is, I think, really shocking. I remember when we first presented this data, people would tell me, I don't know what you're talking about. All my patients are taking their medication. So I think people didn't really recognize this as being a big issue. So what are the implications of not taking your hormone medicine if you have breast cancer? Well, this is observational data that we reported that showed that patients that discontinued their medication or took it intermittently had worse survival than those that took it regularly. And you can see there was a dose response rate. So the less you took your medicine, the higher your hazard ratio was for overall mortality. We were always pretty shocked by this data, but also recognizing that observational data can be misleading because sometimes when patients stop taking their medication, they have other health behaviors that can influence their outcomes. So you don't really know if this association is causal. We were reassured by subsequent studies that looked at prospective data, patients that were enrolled in adjuvant trials. And patients that enroll in clinical trials prospectively are sort of the best of the best because they've agreed to be part of a prospective randomized clinical trial to begin with. So they usually are fairly conscientious about their health. And this is a study that looked at patients that stopped taking their medicines but restarted versus those that stopped and never restarted. And patients that restarted taking their hormone therapy after discontinuation had better, not just overall survival, but disease-free survival, suggesting that there is more of a causal relationship between stopping your medication and breast cancer outcomes specifically. But back to the point where we know that patients that stop taking their medicines have poor outcomes, we know that patients that are discontinuers or non-adherents, less than this 80% cutoff based on medication possession ratio, have worse outcomes overall, not just for cancer, but for other outcomes. And this was a really interesting study where they looked at patients that were enrolled in the Women's Health Initiative, and they only looked at patients that were in the placebo arm. So all the patients that were in the placebo arm, patients that were non-adherent to their placebo pills had a higher risk of death. They had higher risks of hip fracture, higher risks of an MI, and higher risk of cancer death. So There's a lot to this non-adherent behavior that goes above and beyond sometimes whether or not you're taking the medication. So when we think about factors related to non-adherence, they get grouped into multiple different categories. There are social and economic factors associated with non-adherence related to health literacy, lack of health insurance, the cost of medication. There are system-related factors, meaning related to the patient-provider relationships, lack of continuity of care, waiting times between being able to get back to your physician, condition-related issues like symptoms, both side effects of the medication, but also no side effects of the underlying condition that can be related to adherence. Therapy-related factors such as the complexity of the medication, how long you have to take it, and both actual and perceived side effects. And then patient-related factors about their understanding of their disease, their motivation and confidence, their perceived benefits of the treatment, and then other factors such as cognitive impairment that can impair a patient's ability to take their medications every day. And we've looked at a lot of these different factors in relationship to cancer, as have other people. I'm going to really talk about three main branches of non-adherence related to cost, related to side effects, and related to patient behavior. So first, to start out with cost. This is a study we did looking at copayment amount. And this was in the era of aromatase inhibitors, one of the hormone therapies before they went generic, where some patients had very high out-of-pocket costs. And we looked at monthly costs and rated it as less than 10 to 20, and greater than $20 per month, and found a direct correlation between the amount that you pay out of pocket and your likelihood of being adherent over time. We also looked at what happened when these medications switched from generic to from brand name only to having a generic alternative. And interestingly, all of the aromatase inhibitors had generics within a year of each other. And as soon as generics became available, patients that started generic medications and also had a lower out-of-pocket cost were more likely to be adherent over the long term than those that got brand name, even controlling for the cost of the medication. So how you start out with the medication can influence your likelihood of staying adherent over time. This is a study that sort of replicates those results, looking at Medicare data and issues related to the donut hole. If you are on a low-income subsidy and never lose your insurance, you're more likely to be adherent than if you don't have a low-income subsidy. And you can see what happens with each time people run out of hit their donut hole, their adherence goes down. This study looked at the introduction of generics and modeled out that as soon as generics were introduced after 2010, patients did not have those same subsequent dips that would have been resulted in decreased adherence over time. So generics have a big effect both for patients with low income subsidies and those without. So it's not just hormone therapy over time. We've developed more medications to treat cancer. One of the most common medications that are used for long-term are tyrosine kinase inhibitors for chronic myeloid leukemias. And this is a study that was done by Stacy Dusancina that looked at copayment amount for some of these other medications. And these medications are far more expensive than the medications that we give for breast cancer. And you could see here that higher copayment amount, if you were in the top quartile, the relative risk of non-adherence was 1.7 for discontinuation and 1.42 for non-adherence to these medications, showing this relationship persists across multiple different cancer types. This is another study that was done by their group that looked at the impact of parity laws. And parity laws were developed to try to lower out-of-pocket spending for patients. And they looked at patients that were both fully insured and patients that were self-funded, both pre-parity law and post-parity law, looking again at tyrosine kinase inhibitors and other immunomodulator drugs. And if you look here for both of these drug classes, the parity laws made a difference. This light gray curve are patients that paid, had zero copayment over time. And you can see that increased over time, and they found subsequently it was related to increased adherence. But if you look at patients that are self-funded, these kind of laws have no impact. In fact, they increase their out-of-pocket spending. And in this dark curve at the top, these are people that paid more than $100 a month. So while these laws and policies improved out-of-pocket spending for patients that are fully insured, they actually increased out-of-pocket spending for patients that are not fully insured. So it's not just how much insurance you have, it's also about how much money you have and what your net worth is. And this is a study that we did with a novel linkage that looked at patients' overall net worth in terms of how much they own and number of cars they have, their zip code districts. And as you go down in net worth, your adherence over time to hormonal medications goes down. So it's related to a combination of factors. And interestingly, what we found with net worth is that there's a huge disparity. We know that Black patients and Hispanic patients, other high-risk groups are at greater risk of being non-adherent to their medications, but it's not all patients. And there's a large interaction between net worth and insurance and race when we think about adherence. There's no racial disparity that we can see in patients that, Black and white patients that have high net worth or low net worth. Some of the disparities are much greater in patients with less access as well as less resources we see with low net worth categories. And what we did was we created a model where you can see that race had a big impact in terms of likelihood of being adherent to medications. But once you start to correct for net worth and copayment amount, you pretty much correct a large portion of that disparity. So in addition to cost, we know that side effects are a big factor in terms of non-adherence. If you want the treatment to have its ultimate effect on outcome and quality of life, you have to be able to control symptoms, you have to recognize them, you have to have appropriate symptom management, because without it, patients stop taking their medications. And we know that our hormone therapies for breast cancer cause a lot of side effects. Tamoxifen can cause vasomotor symptoms, gynecologic complications such as decreased libido, vaginal bleeding, even endometrial malignancies, and put patients at higher risk for thromboembolic disease. Aromatase inhibitors cause substantial joint pain, what we call musculoskeletal symptoms, also vasomotor symptoms, vaginal dryness, decreased libido, and bone loss. So these medications do interfere with patients' quality of life. And we know from prospective studies from randomized trials that have looked at not only who stops medications, but reasons for stopping medications, looking at both tamoxifen and aromatase inhibitors, that these side effects are a major reason why patients stop taking their medication. Specifically for the aromatase inhibitors, that joint pain can result in a substantial number of patients stopping taking their medications. Thromboembolic events stop patients from taking their tamoxifen. And you can see down the line, a lot of the vasomotor symptoms and menopausal symptoms stop patients from taking both of the medications. This is a study done by the group in Michigan, Lynn Henry's group, looking at discontinuation over time with different types of aromatase inhibitors. While it doesn't seem to matter too much which type you take, they all result in discontinuation. About a third of patients discontinue due to adverse events and effects of the medications, and 25% specifically due to musculoskeletal symptoms. And it's important. We've done a lot of work describing musculoskeletal symptoms on these medications and defining interventions to try to reduce it. That's where symptom management can have a huge impact in terms of not only improving patients' quality of life, but if you can keep patients on their medication, you can ultimately improve their outcomes. And we've looked at various different things like various supplements like omega-3 fatty acids. We've looked at exercise. We've looked at acupuncture. And we sort of say whatever intervention works to keep somebody on their medication, it's really worth it. But when we think about that disparity, there's a strong interaction with symptoms. And this is a study done by Stephanie Wheeler last year that shows that there's a disparity in side effects leading to endocrine therapy non-adherence. And you can see that Black patients report more hot flashes, more joint pain, more vasomotor symptoms, all of which are the reasons for increased discontinuation in this group. So improving symptoms can also potentially help reduce disparities. So we know that patients' quality of life and behaviors and interactions with the healthcare system can also impact their likelihood of staying on their medication. This is a study that we did off of a cohort study in Kaiser Permanente, looking at baseline factors and subsequent adherence, and how satisfied a patient is with their medication, their global satisfaction, how convenient they think their medication is associated with less non-adherence. Patients that have PTSD symptoms from their breast cancer are actually more likely to be non-adherent. We measure that through a scale called the impact of events. Patients that state that their doctors didn't explain clearly their medications are more likely to be non-adherent. It's sort of self-evident, but it does let us know that there are factors that we can do to intervene in terms of our own communication skills. And ultimately, patients with worse quality of life when they start their medication have significantly more non-adherence or less adherence. So knowing where patients are when they start is an important factor. We know that patients that are non-adherent can be non-adherent to other medications. So this is a study that we did that showed at the initiation of endocrine therapy, patients that are non-adherent to their other medications, like their antihypertensives or their thyroid medicine, diabetes medicines, are considerably more likely to be non-adherent to their hormone therapies. And if you're an adherent person, you're more likely to be adherent to your medications. And there's a dose response to this. So the more adherent you are to more medicines, the more adherent you are to your endocrine therapy. So if you're on multiple medications that you're adherent to, you've sort of got your systems down and you're more likely to sort of follow the directions and do what your doctor tells you to do. Interestingly, also, we have to think about non-adherence to medications for chronic conditions in patients that are diagnosed with breast cancer. And what can be very worrisome is that when a patient's diagnosed with breast cancer, they're more likely to become non-adherent to their medications for their other chronic conditions. So this is a study that showed decrease in adherence to patients' hypertension medication, cholesterol drugs, diabetes drugs, thyroid drugs after a diagnosis. So when we think about improving outcomes for breast cancer patients, we have to pay attention to their other comorbidities and make sure that patients don't stop taking their other medications. Because stopping taking your medications for these other conditions actually impacted outcome. And this study showed that patients that after a diagnosis of breast cancer that became non-adherent to these other medication classes had a higher risk of cardiovascular events. So it is important for their general health, but to reduce their cardiovascular mortality, and non-adherence has a major impact on that. And again, the more medications patients were non-adherent to, the more likely they were to have cardiovascular events. It sort of goes without saying that if a patient stops taking both their blood pressure and their diabetes medications, they're at even higher risk of having higher cardiovascular events. So what can we do about medication non-adherence? Various different people have looked at interventions. Interventions sort of fall into multiple different categories. Patient education, so studies looking at telephone counseling, trying to reduce the complexity of medication regimens, clinical pharmacist consultations, including education and more frequent disease monitoring. Cognitive behavioral therapy has been looked at in terms of motivational interviewing, both at the patient level as well as the provider level. Reminders have been looked at, other types of incentives to promote adherence. This is sort of looking at the overall adherence literature, not just cancer-related factors. We, in our group, looked at whether or not text messaging educational intervention could reduce discontinuation. We knew from prior studies that things like knowledge and beliefs about medication could impact, knowing that there might be treatments if patients had side effects. So we did a lot of pilot studies and conducted a study where patients were randomized to receive two text messages a week over a period of 3 years versus usual care. And the question became, how are we going to measure adherence in this prospective study? And I think that's one of the problems with almost all the studies, because the vast majority of these interventions, they look at 2 or 3 month adherence rates, which really don't capture endpoints that affect outcome. So we decided to look at urinary aromatase inhibitor biomarkers to see if we could tell whether or not patients were still taking their medication. So this was not a reminder intervention. This was an intervention to really overcome barriers, such as, really inform patients about the efficacy of the medication, to reinforce physicians' recommendations, and to offer encouragement to take their medication. Examples include, even though taking your medicine may be hard, it's worth the benefits. If you're having side effects, it's important to tell your provider. If you don't want to take your hormone pills, tell your doctor before stopping. Things that we thought might cue patients to action if they were thinking of stopping their medication. And as I said, the primary outcome for this, we did it as we would any other kind of randomized intervention, where we looked at time to adherence failure. And we classified adherence failure as either not having urine that showed that patients were taking their medication, or it was undetectable. But we also had to classify patients that didn't submit their samples, so they stopped coming to their appointments, as being non-adherent, because we had no way of knowing whether or not they were continuing to take their medication. So in addition to looking at this primary outcome, because it's so challenging to study non-adherence, we had many different secondary outcomes, including patient self-reported discontinuation, site reporting discontinuation. In addition to looking at time to treatment failure, we looked at different time points, such as 12 months, 24 months, and 36 months, because having a one-time event may not really represent non-adherence. So in this randomized trial, we randomized close to 700 patients. They were evenly distributed between the text messaging group and non-text messaging groups. The vast majority of patients on the trial were on the medication for less than a year at enrollment, and had higher risk cancers, meaning they, 40% had had chemotherapy. The vast majority were, they were all on aromatase inhibitors, and most had not had prior tamoxifen and switched. And these are the results. It was pretty sobering. Time to adherence failure amongst these subjects was exactly the same in those that received these biweekly text messaging as those that did not. But I think based on our definition of having a single non-adherent event, the vast majority of patients had an event over the 3-year period, which is really quite sobering. When we looked at this in a more cross-sectional analysis, which is probably more representative of patients' non-adherence, you could see that per year, patients' non-adherence really went down, as you might expect for a study like this. Exactly the same between the intervention and non-intervention groups. We did sensitivity analyses, so people that submitted their samples but did it a little bit out of window, we counted. And no matter how we looked at it, there was no difference between the two groups, but adherence went down. And it really just goes to show, to reiterate that what I said at the very beginning, which is how you measure adherence has a big impact on what you call adherence rates. For us in this study, no matter how we measured non-adherence, there was no difference between the groups. So we felt very confident that our intervention had no effect. But you can see that if you measure non-adherence, very, very liberally, as we did, almost everybody is non-adherent at some point. Once you start to put in restrictions, then you start to see rates that are closer to 20%. When you ask patients whether they stop taking their medication altogether, about 10% said they did. But when you ask providers, about 20% said that patients stopped taking their medication. So you see that how you measure non-adherence is wildly different from patients to providers to having a time to event analysis versus a cross-sectional analysis, all of which can impact outcomes and make studying this extremely challenging. We looked at in this study whether or not we could predict non-adherence, and this is information we presented at San Antonio last year, and the manuscript's in press, and we looked at baseline. So patients that had said that they were taking their medications regularly at enrollment and had at least 3 years left to take it, some of the same factors emerged. Patients with worse pain, worse quality of life, patients that didn't have a good understanding of their medication based on their baseline medication questionnaire, and patients that didn't think their medication was effective or convenient, all were at higher risk of stopping their medication, even though they had been on it on average for about a year. What was interesting is that patients with more risk factors, as you might imagine, were more likely to be non-adherent. And if you were scored in that high range on all of those different factors, you had a 3-fold increased risk of being non-adherent. About half those patients were non-adherent over that 3-year period of time. And maybe one of the issues we're seeing is that in these trials, we have to figure out better ways of targeting the patients that are the most at risk so that we can target our interventions and our strategies a little bit more effectively so that our strategies really target the reason why somebody may be non-adherent to their medication. So we are always humbled by research. It's humbling because it's so hard to do. But we're not the only ones that have had a challenging time trying to figure out interventions to improve adherence. And this is a study by Kevin Volp, who's like the guru of behavioral economics out of University of Pennsylvania. They did one of the best design studies I think I've ever read, which looking at medication adherence for patients with cardiovascular disease risk factors. This study did it all. They looked at electronic reminders. They incorporated financial incentives in to encourage patients to continue to take their medications, and they offered social support to improve outcomes. And they looked at the highest risk patient population. They looked at patients that had had a myocardial infarction. So these are patients that were at risk for having an event. And what they looked at was whether or not this threefold state-of-the-art behavioral economic approach to intervention could improve medication adherence and reduce readmissions following an MI. And they found that this intervention really had no impact on readmissions, no impact on any type of admission, whether it was for cardiovascular event or not, and really had no effect on emergency room visits or medication adherence overall. It didn't impact hospitalization effects or medication costs. So even the best designed studies are extremely difficult to do. So where is this field going forward, knowing how challenging it can be to improve adherence? A lot of people are interested in using health technology interventions to improve medication delivery. And, you know, it's really quite challenging. One of the problems we found with our text messaging intervention was that people are overwhelmed with alerts. In this election season, I get a text message about every 10 minutes. And, you know, from all different types of sources, plus multiple emails a day. And, you know, the reality is that we have to really strategize about our interventions so that people don't sort of turn off to the intervention. We really learned our lesson that just alerting patients and providers may have, not be really beneficial. In a study we did looking at trying to reduce GCSF administrations when patients were hospitalized with neutropenic fever. And we figured, well, if we alert physicians and tell them what the guidelines are, that right then and there, they'll be less likely to prescribe an ineffective medication. And what we could see was not only did that have no effect, but we could see that patients just click the buttons repeatedly to get past all the alerts to move on to do what they want to do. And in this age of electronic medical health records like Epic, a lot of alerts and systems are put into place to try to improve quality, but patients and providers can figure out ways around them so that they're not so distracting. So in thinking of new ways to intervene, I think we need to think about things that will be acceptable to patients and not onerous to providers. I had mentioned earlier about digital medicines, and they're actually a really interesting way to measure adherence. Digital medicines, as I said, co-encapsulate the actual medication with a copper-based pill, so that when the copper hits the acid in your stomach, if a patient's wearing a patch or a Fitbit, it'll send an electronic alert. And that information from that sensor can go into the cloud, and you can see, based on patient symptoms, when patients are taking their medication. This type of digital medication program was first approved for a medicine called Abilify, which is used to treat patients with psychiatric abnormalities. And the concern in that scenario is that if somebody stops taking their medication and because they have underlying psychosis, they will, because they're feeling better, then that can trigger a psychotic event. And if you can put these alerts in and have those alerts maybe notify a care provider or a family member if a patient stops taking their medication, you could potentially intervene early. So this digital medicine is FDA approved, and it became FDA approved to be given along with Abilify. I think it's called Abiliset. to try to help monitor patients. And the question is whether or not patients that know that they're being monitored figure out alternatives, and whether or not it's off-putting to patients to know that they're being monitored. They tried to do the same study looking at capecitabine, which is an oral medication, so that the thought was that you know exactly when patients were taking their medication and not, in relationship to maybe when they develop symptoms such as diarrhea. We had a similar use of this medication for opiates when patients complained of pain, so that we could provide information to their provider. However, with COVID, this company went belly up, so to speak. And so we're looking at other alternatives to provide digital information back to providers to help guide their medication prescribing. Other alternatives have been looking at smartphone apps. This is one smartphone app from Medisafe. We have many studies looking at this one Medisafe app, although there are hundreds, if you look at the App Store, of different technologies that are available to patients. There are some studies that suggest for antihypertensive medications that it results in improved adherence. These apps can get complicated. You can see electronic pill bottles so that you know when to take your medications or get alerts if you forget. They can also remind you when it's time to refill them, or inform your provider or caregiver if you forget to take your medicine. So trying to figure out the right sweet spot between not being too intrusive, but helping patients with their medication is a current active area of investigation. Another thing that we're doing is looking at electronic pill bottles in a way that's a little bit different than MEMS caps have been used in the past. And this is a device that we're currently studying, looking at patients that are prescribed opiates, where our study involves post-surgical patients that are getting opiates for a short period of time. And patients, when they want to take a medication, they go into an app, they rate their pain on a scale of 1 to 10, and then the app gives a 4-digit code. They put the 4-digit code mechanically on the app and it just on the dispenser, and it dispenses the medication. So it's a way of keeping track of how much medication the patient's taking. And then it gives them cues in terms of when their pain goes down that they should consider switching to NSAIDs, or maybe they don't need to be taking their opiates anymore, to help people taper off of opiates quickly to deal with some of the problems that we're seeing of people taking opiates chronically. And one of the really interesting things about some of these devices is that other people can't get into it, so that we see that one of the issues with opiate overdoses is maybe children getting into their parents' opiate bottles. And as soon as you're done, you can actually put it into a mailer and send it back, so that you're not dealing with excess medication. So trying to figure out how to use technology to help people take the medicine when they need to take it, stop taking it when they don't need to take it, and control their side effects is really an active area of investigation. So in conclusion, medication non-adherence is common. It's common in cancer. It's common in all chronic conditions. In cancer, we've seen an explosion of new medications. When we first started doing our study, there were few oral medications. Last year, there were 14 oral medications approved for cancer. Not only are there more medications, but they're extraordinarily expensive. Medications cost, some of the anti-cancer medications cost between $11,000 and $16,000 a month. Medications for hepatitis C cost thousands and thousands of dollars. So the issues related to cost and waste and non-adherence are only going up. So trying to figure out ways to reduce that is exceedingly important. There are multiple factors that contribute to non-adherence, many of which could be modifiable. So really trying to find the best interventions for the best patients and identify patients prospectively before initiating treatments who may be at the highest risk is an area of investigation. I think we need to be humbled by the fact that measuring adherence is challenging, and interventions, even the best interventions based on the best science, can be challenging. So we need to expect that we'll need to do multiple studies and that our interventions may fail, but that we can learn from them anyway. And small changes that we make can have a big impact on outcomes. So we need to accept each small change as being a major success. And ultimately, the path forward is to try to figure out how to find that sweet spot between using novel technology and behavioral economic theory to find the best interventions to improve cancer care delivery. So I'm going to end there and leave some time for questions.
Great, perfect. Thank you, Dr. Hershman, for a sobering view of the world after our patients leave the office. I'm going to start off with a couple of questions that I have. So the data about the copay was interesting, and I'm thinking of tobacco cessation programs, weight loss programs. In those settings, having the patient pay something actually increases adherence, and they have some skin in the game. And most of what you showed was sort of less than 10. Is there anything looking at zero copay versus $1 copay in terms of adherence? Is the first question. And then the second is, do we know anything about physician adherence to medication? Are we as a group better or worse, or we just reflect society? So I will stop there.
Yeah, I mean, I think it's probably pretty hard in the oncology world to figure out that level of granularity from adherence, because usually the co-payments are tiered. So out-of-pocket costs are grouped, and the vast majority have either none or something small like $10. But what we see in oncology, which is some patients pay thousands and thousands of dollars per month, which is prohibitive. And so we know that non-initiation, so never filling the prescription, is related to higher amounts, and probably lower amounts are related to people taking multiple medications, each of which, have a copayment. So, we don't really know the granularity of what an incentive would do, like if you paid somebody to take it, as opposed to the hurt of taking taking it away. In terms of physicians, I mean, it wouldn't surprise me if we're just as bad, if not worse, than the general population, but I haven't seen studies specifically looking at physicians.
Okay, great. And Ruth, do you want to ask your question? While she's looking for her unmute button. How do our adherence rates compare to other countries? Is it a U.S. specific view of a lack of trust in science, or is this a worldwide phenomenon? Thank you.
So I know in breast cancer anyway, I think what's quite shocking is that the non-adherence rates are dismal and consistent from country to country, and that some of the factors that affect one country may be different in another. So even in healthcare systems where there are no out-of-pocket costs, where medications are provided to everybody, there's still non-adherence. And we see from those clinical trials, even when medications are given to patients, there's substantial non-adherence. So I think it's multifactorial. If you have side effects and you have to pay, then it's even harder to sort of deal with it. I think that our patterns for how we explain things, how much time we have, probably differ from country to country. But it is interesting to see that the rates are pretty similar, even amongst countries where co-payments aren't an issue.
Okay, thank you.
All right, Lynn, I'm back now. Sorry for that. So Dawn, I think we struggle so much with this. I mean, it's our daily conversation with patients about not taking endocrine therapy. And I guess I'd love to know if you have any little secrets in terms of how you can actually encourage people to take their medication, because I find it very challenging. And I had a patient who I was following her for 5 years. At the end of 5 years, she told me that she'd flushed every tamoxifen pill down the toilet. She filled them and flushed them down the toilet. So, yeah.
Right. And she would have been counted in some of these studies of being adherent because she was picking it up every month. I mean, I think that's why it's so sobering and challenging to study. I mean, it's really devastating because, on multiple different levels, I think the most important thing is to ask patients, right off the bat, at every visit, are you taking your medication? And then really try to get at the reasons why. If it's because of cost, often as providers, we can try to figure out how to get some payment assistance or, get the company to give them the medications now that they're generics. Often that's something that we can control, or we can switch the medications. I think in terms of side effects, we've made a lot of progress in terms of thinking about things to improve side effects. I usually go down the list and say, we can try this, we can try that. I think one of the things we're learning is that, especially with these oral medications, that the dosing was based on maximum tolerated dose as opposed to minimally effective dose. And we're learning that even lower doses may be just as effective. And so there's a lot of research in trying to figure out how we can figure out the right dose for the right patient and maybe get the dosing down. So I usually tell people, like, even if you're taking a half a pill a day, based on some of the tamoxifen data, you may be getting something. So let's try. Ultimately, I think as a provider, you have to try to partner with your patient. And you have to look at their risk. Maybe the patient doesn't need it for as long. So using using some of these genomic approaches to try to figure out, maybe patients don't need it. Some patients need it longer. We can try to focus our efforts on the people that need it the most. I think one of the most devastating things, like, I have a patient that I just saw last week who, I didn't realize, but lost her insurance 2 years ago, stopped taking her medication, and now has metastatic disease. And if we had known, we could have gotten her medication, and I think that's the most devastating thing, I think, as an oncologist, to see that. And, trying to figure out how to improve access, which is modifiable. Some of these other things are not, I think, is a huge priority.
Great. Thank you. And we have a couple of questions from our residency program, so I want to make sure we get to those. So Lauren Banachek, were there differences in adherence after text messaging interventions based on age? Do younger people do better with those, or is it across the board?
It's actually across the board. I think younger people probably are getting more texts and have more distractions. Maybe some of these other electronic interventions are easier for some patients than others, but even in the one study we did, they were all postmenopausal patients, or some were younger postmenopausal patients, but we don't really see a difference. I mean, surprisingly, a lot of people have access to phones and internet and technology, even elderly patients. So it doesn't seem to be a huge barrier as it used to be.
Great. And then from Kelsey Herbert, do you have language that you typically use to introduce or talk about the digital adherence tools or the copper technology with patients, et cetera?
Yeah, I mean, everything we've done with that has been as part of a research study. So, so I haven't had the experience of using the Abilify myself, but I think, you know, from talking to the company, they say, like, with explanation, patients are very eager and willing to do it. So, yeah.
And then from Powell Hudson, an interesting question. Given the high cost of so many of these drugs, should we actually have a threshold of adherence before we dispense them in the future?
I mean, I think that's an excellent question because we waste so much medicine. I wish I knew the answer to that, but I think, you know, the higher the medication, the more the interventions are important. So maybe we don't need to digitize aromatase inhibitors for 10 years when the costs are low. But maybe for medications that are $11,000 a month, we really need to keep track of it better rather than giving it, you know, multiple months when patients aren't taking it.
Right. And then our final question from Dan Mulcairn. Do you have data between differences in adjuvant or prophylactic hormonal treatment, for example, compared with kinase inhibitors for active cancer?
Yeah, it's actually interesting. So, you know, patients are on tyrosine kinase inhibitors with active cancer are also non-adherent. Patients on Xeloda are non-adherent. Patients on palbociclib for metastatic cancer are non-adherent. So, and patients in the adjuvant setting, so where they know if they stop taking their medication, their cancer can come back. The rates of non-adherence are almost identical to those that are on prevention. So patients that don't have the disease at all. So it's an interesting phenomena.
Yeah. All right. Well, we're out of time. Thank you so much for insight into this world and lots of opportunities for us to make improvements that in some ways low-hanging fruit to improve the outcomes. And I appreciate it and hope to host you someday in person.
Looking forward to it. And the ice cream. Thank you so much. Take care.
Take care, everyone. Have a great weekend. Bye-bye.